Okay, so welcome to the next lecture on the elbow, forearm, and wrist. We are leaving the scapula and the shoulder behind through the shoulder girdle and the shoulder joint, and we're moving our way down. Now, we'll be revisiting things like the biceps and the triceps, brachii, because they do cross the elbow, and they are primarily agonists over the elbow joint. Of course, some of them do cross the shoulder, but we're going to focus on them more in their function around the elbow. And then, of course, we're going to go into the forearm. This is a very complex area of anatomy. In many cases, people say it's the hardest area of anatomy, but it's really just a bunch of strings all attached to the wrist and the fingers to make things move. So we're going to be going through this extensive list of muscles in the forearm. So we'll be looking at the elbow joint, the forearm joints, and the wrist joint, and how the muscles work around these regions. So let's get started. So the learning objectives, this is really the same for every week. It's just region specific. So this region, we're looking at elbow and forearm. So we're going to identify some of the main structures around this area, which include the bones, the joints, special structures, and primarily deep and superficial muscles. Then we'll describe how each of these muscles actually function over the elbow, the forearm, and the wrist. And then in the pracs, we're going through the palpation of these regions and the bony landmarks. We're going through range of motion of the joints, and then we're going into some functional tasks to help understand how these muscles actually function for us in life. So let's start with the movements that are available in this region. So as you can see in this top left picture here, we have the humerus articulating with the ulnar. Now this joint, the humero-ulnar joint, is probably the largest. It is the largest articulation of the elbow, so it's sort of the true elbow joint. But then of course we have the radius articulating with the humerus on that lateral side as well, which just goes along for the ride in the main movement of the elbow, which is flexion and extension, as depicted here. You can flex your elbow and you can extend your elbow. Now, beyond that, you can also do a movement around your forearm. So this radius here, it can actually sort of fold over the ulnar. And when it folds over and they kind of cross over, that's called pronation, where your hand is facing down. And then you can supinate, where your hand is facing up. So although it is a spinning motion between the radius and the humerus up in the elbow, it's truly a forearm motion because it's mostly happening at this proximal radio-ulnar joint between these two bones and the distal radio-ulnar joint, right, between the radius and the ulnar. And it's really just a folding of the radius over the ulnar. Now the ulnar does move to some degree with this, but it's negligible compared to how far the radius moves, right? So this is pronation. It's where your hand looks like it's facing down. Supination, hand is facing up. You can say, I'm serving you some soup, right? Here's a bowl of soup. Oh, did you make that soup? Yeah, I made that soup. I'm a pro. Don't worry about it. I made the soup. I'm a pro. That's how I remember it anyway. And flexion extension, easy to remember. So, movements at the wrist. So because a lot of the forearm muscles will be crossing the wrist and going into the fingers, we'll just cover the movements of this region now. So the wrist can flex and it can extend, okay? In anatomical position where my palms are facing towards you, flexing is like lifting the hand up and extending is reaching it backwards. And in anatomical position with your hands by your side and your palms facing forwards, you can also sort of tilt the hand outwards, right, towards the thumb side. And that movement is called radial deviation because you're deviating the hand towards the radial side of the forearm, but you can also call it wrist abduction. I prefer radial deviation because everything else is abduction, adduction. And then the opposite, you've got ulnar deviation, where the hand is deviating towards the ulnar or medial aspect of the forearm, right? Ulnar deviation, also named wrist adduction. Now, all of these movements of the forearm, the elbow, and the wrist, they all kind of happen, they have typical movement patterns that they follow. And so this is one typical pushing movement pattern that you tend to do with any kind of throwing movement, particularly in basketball. And that's where the elbow might extend, and as it does that, the forearm will pronate, okay? It's twisting. The wrist will flex, because the purpose is usually to propel something, so using flexion, and with flexion sometimes comes with that ulnar deviation, especially if you're trying to make it flick to some degree. Okay, so that's just a typical movement pattern that you can see in many throwing sports. It can be slightly different in cricket, where you might want to flick it in a different direction. Okay, so now onto the passive structures of the elbow. So these are quite important. The elbow itself is a pretty stable joint. Like, it has quite a lot of congruency between the elbow and the humerus. As you can see, that trochlear notch of the ulnar really has a lot of surface area with the trochlea of the humerus. So it is quite a congruent joint. However, it also gets a lot of stability from these ligamentous structures. So let's have a look immediately. So the first thing, if you look on the inside of the elbow, you've got the medial or ulnar collateral ligaments, and it's because they're on the ulnar side or the inner side of the elbow. So they sort of span from that medial epicondyle, and then they'll be attaching to the ulnar, like the coronoid process of the ulnar, and then spanning backwards from there. It comes in 3 parts. The anterior band of the ulnar collateral ligament, it's the thickest and strongest band. Then you have this posterior band, which is kind of like a triangular extension. And then you have this inferior band, inferior ligamentous band, which is a strange band because it doesn't actually cross the joint, so it doesn't stabilize the joint so much. It just helps reinforce the entire ligament. So those 3 bands, the anterior, the posterior, and the inferior, they make up the ulnar collateral ligament. So moving laterally, we've got the lateral collateral ligaments, or the radial collateral ligament, and so it has sort of 2 bands. One of them actually, funnily, extends back to the ulnar, which is weird because it's a radial collateral ligament, but instead of going straight to the head of the radius, it sort of branches backwards to the supinator crest of the ulnar. And yeah, but it still reinforces the lateral aspect of the elbow. It just doesn't go to the radius. But then the anterior portion of the band does go into the radius, and it sort of blends with this annular ligament here. And the annular ligament is a ligament that goes from the ulnar and goes right around the radial head and attaches back to the ulnar. And so the the annular ligament is just a circular ligament. Annulus means ring, like an anniversary, and it just circles around the radial head to make sure it keeps it in place. Because as the radius spins through pronation and supination, it needs to stay in place and not dislodge. Unfortunately, sometimes when you do fall on an outstretched hand, the radius is the bone that tends to dislocate in the elbow, and it can stretch that band. So what that band prevents is dislocation of the radius and keeps it in its place so it can spin. And then the quadrate ligament, that's just this little strange little ligament here. It helps secure the head of the radius to the ulnar, and it also resists excessive supination and pronation. So as you can imagine, this little rope here, if you twist too much into pronation, it comes taut, and then if you twist too much in supination, it comes taut. So it's just a little check ligament there. All right, so the medial or the ulnar collateral ligaments, the radial collateral ligaments, the annular ligament that comes right around, and then the quadrate ligament. Okay, so now on to passive structures of the forearm. So we're moving down from the elbow and we're having a look at the structures that connect the radius and the ulnar. So the first one, the least important one, is the oblique cord. This is this small little obliquely shaped cord that attaches the ulnar to the radius proximally, just proximal to the interosseous membrane. It's sort of an extension of the interosseous membrane, and it's just an evolutionary remnant, really. Its presence in modern humans is kind of a functional remnant of our quadrupedal ancestry. So it was perhaps quite useful when ancestors were loading through their forearms a lot more for when mobilizing, but we're not using our forearms for that function so much anymore. So it's become quite a small vestigial structure. So it's not something you need to worry about too much. From a functional perspective, it probably doesn't stabilize the forearm that much at all. But what does stabilize the forearm is the interosseous membrane. So we've got this big, broad fascial sheet that extends between the two shafts of the bones of the radius and the ulnar. You'll notice we also have an interosseous membrane in our lower leg, in our shank. And why do we have this big, broad, sort of ligamentous structure? Well, it serves many functions. Primarily, it prevents the migration of the radius on the ulnar in this axial direction. Basically, it unites the two bones. So when force goes through one bone, it dissipates into the other, and it can transfer all of the load so that it's not all focused into one spot. So here's an example of how that works. So this is Achilles. He just is having a whinge because he got shot in the heel with an arrow, and for some reason he's naked in a battlefield with only a helmet. I don't know, that's his deal. But he is weight bearing through his hand. Okay, so the force of the ground is going up through his wrist, and then it's entering into his forearm. Now it does this via the radius. That's because the radius is the main articulation with the wrist. That's why they call it the radiocarpal joint. So as he's weight bearing, all of that force is going into his radius, and it's sinking up, and it's going into his elbow. Now you don't want all of the force of his body weight into his wrist going into the elbow, because that's a small little joint between the humeroradial joint. Okay, it's a small one, and this is how people dislocate their elbows actually, if too much force goes into this joint. So luckily there's this interosseous membrane which transfers the force into the ulnar so that you can dissipate the force over a larger surface area, because of course the humero-ulnar joint is much larger. So that's the true function of the interosseous membrane. It basically shares the force and unites those two bones, so it prevents any migration of one bone on the other. That's pretty much it. But it also serves as a muscle attachment for muscles going into the hand. So as we go through our origins for hand muscles, you'll note that some of them do attach to the interosseous membrane. So now on to passive structures of the wrist. So tendon sheaths. So a tendon sheath are these little sort of sacs of fluid that are looping around the tendons as they're passing through a corner, which is the wrist. And tendon sheaths are basically, they have an outer fibrous component, which can, withstand a bit of friction, and an inner double-layered sheath that's akin to a bursa. So you remember the bursa in the shoulder, it's just a fluid-filled sac. It's sort of the same thing, it's a fluid-filled tube. And they provide well-lubricated, smooth surfaces to reduce friction for movement of the tendons that are within them. So the tendon sheaths have, there's a tendon sheath for all of these tendons that pass through the wrist, and they're all held down on the dorsal side by this extensor retinaculum. And then you can see here there's a flexor retinaculum there. So the tendon sheaths, they just reduce friction of the tendons, and the retinacula, they hold the tendons down to make sure they don't bowstring. And so this is a demonstration of bowstringing. Here, that's where the tendon wants to go. It wants to go from origin to insertion in sort of a straight line, but you don't want that for the tendons and the muscles going to your fingers, because then you just have all these cords coming out of your hands. So we have these retinacula, one at the wrist on the palmar aspect and one on the dorsal aspect. You have them in the hand and the fingers, and they basically keep the tendons down so they stick to the bone as you're moving the joints. All right, so a retinacula just holds tendons down. So you've got one at the front of your wrist and one at the back of your wrist. And then finally you have a palmar aponeurosis. So the palmar aponeurosis it acts as an insertion point for some muscles. This is a palmar aponeurosis right here. It attaches to the skin of the hand, and it's actually the insertion of palmaris longus, which is sort of that tendon there, and also palmaris brevis, which is a muscle of the hand. So its real function is when muscles are tensing through the hand, it attaches to the skin and creates, it pulls the skin taut, right? So when you're gripping things with your palm, the palm skin doesn't move too much. It basically keeps it taut, so it doesn't move relative to the things you're holding, and increases your grip. Really, that's its main function. It just increases your grip. but also acts as an insertion. Yeah, so that's the tendon sheaths, the retinacular, and the palmar aponeurosis. Okay, so this is an example where the tendon sheath and the extensor retinaculum can cause you some grief. It's a condition called de Quervain's tenosynovitis. So yes, it's pronounced de Quervain because it's a French name from this Swiss guy, Fritz. What is it? Well, this is the definition. Let's see if you can understand it. It's a fibrous tissue deposit and increased vascularity of the synovial lining resulting in thickening of the tendon sheath and entrapment of the tendons that pass through it, which is the abductor pollicis longus and the extensor pollicis brevis. So it's these tendons in your wrist, basically because they're having to go around the corner of your wrist and your thumb, where that synovial sheath passes through the extensor retinaculum, it just causes irritation. And this can be quite common. Why is Fritz holding a baby? Well, this can be called baby wrist or mummy's thumb. I've heard it be called these terms. And that's because it's common in new mothers and fathers who are constantly supporting their baby head, and especially in breastfeeding. So if you're supporting a head for an extended period of time. And it's usually because the wrist is held in a little bit of flexion, the wrist is in a bit of ulnar deviation, and the thumb is in extension. So your thumb is constantly in this sort of twisted position, and sustaining that position under pressure. That's where this condition can come in. But anyone who does manual handling and sustained positions of the thumb and the wrist can also get it as well. So that's just pathology relative to this area. So other passive structures of the wrist. So just like with the elbow, we've got a radial and an ulnar collateral ligament of the wrist. The medial and the lateral collateral ligaments of the wrist. And they basically prevent the extremes of ulnar deviation and radial deviation. Okay, so as you can see here, this is a palm. Let's say it's the front of the palm, so the palmar aspect. So it's going into ulnar deviation here, and then we have the radial collateral ligament, which will be preventing it. Right? It prevents excessive movement. So both of these ligaments, they'll just prevent excessive movement in the opposite direction. Okay, and really all of the ligaments of the wrist and the radiocarpal joint, they're all kind of one big sheet, but they align themselves in different directions based off where there's more force. So that's the typical case of these two ligaments. Now, if you look at the wrist from a bony aspect, you can see that there's just this little gap here. Boop. So you can plug that gap with a structure called the TFCC, or the triangular fibrocartilage complex. It is sort of like a little meniscus. It's a fibrocartilage sort of disc or ring that sits in that area and allows for there to be a little bit more congruence in the joint. So there's not just this big gap between the ulnar and the carpals. But of course, because it's a fibrocartilage disc, it won't be load-bearing as much as between the carpals and the radius. All right, that's why we need that interosseous membrane, but it is there to help support that aspect of the wrist. And unfortunately, it can also get damaged. So those were the passive structures that we went over. We've got that oblique cord hanging out in there. We've got the big interosseous membrane. We've got the ulnar and the radial collateral ligaments of the wrist. And of course, there are many other radiocarpal ligaments here, but clinically, they're not as important. But functionally, the main things we're looking at are the structures that are withstanding the most force. So we've kind of gone over those ones. So that's it for the passive structures. Okay, so now we're getting onto the active structures of the elbow. So I'm just going to go briefly to orient ourselves over the muscles of the forearm and the upper arm, and then we're going to go into them individually and a little bit more specifically. So let's start with just orienting ourselves. So from the posterior aspect of our upper arm, we can see that we have the triceps brachii. You can here see the lateral head and the long head, but the medial head is deep to them. You can't really see it very well. Just below it, you have this little triangular muscle called the anconeus, and that will just be attaching the humerus to the ulna here. And those two muscles, the triceps brachii and the anconeus, they would be the prime movers of elbow extension, all right? The agonists of elbow extension. If we look anteriorly, we can see the biceps brachii. Here's the short head, and that's the long head there laterally. It is an agonist of elbow flexion alongside its buddy brachialis, which is just deep. So if you go deep and take away biceps, you can see the brachialis underneath. Now remember, brachium means arm. So every time you hear brachium or brachii or brachial, it just means arm. The brachial plexus, the biceps brachii, the brachioradialis, the brachialis, it all just means arm or relating to the arm. And the final muscle is the brachioradialis, so it just means the arm radialis. That's because it's on the radial side and it attaches to the arm. And here you can see the brachioradialis. Now I'm going to use the brachioradialis to orient ourselves, and now we're going to go through all of the muscles of the forearm. So strap in. We're just going to go through the orientation of it, and then we'll go through each of them a little bit more in detail. Here we go. So, active structures around the wrist and the forearm. So we're starting with the brachioradialis, which is this thin structure here. You can only just see it from the posterior aspect. You can see a lot more of it here from the anterior aspect. But we'll start posteriorly. So that's brachioradialis. The next muscle across is the extensor carpi radialis longus. Okay? It's named that because it extends the wrist, the carpals, extensor carpi. It's on the radial side of the forearm, and it's the long version of the muscle. So brachioradialis is a big brachial muscle that attaches up to the arm. It sort of does the same thing. It attaches further up than the other muscles of the extensors. So that's why it's the longest. So you've got brachioradialis, extensor carpi radialis longus. If there's a longus, there's got to be a brevis. So the brevis is the muscle that just goes, is the next one over. So that's the extensor carpi radialis brevis. And then right here that kind of courses into the middle of the forearm, that's the extensor digitorum. And that helps extend the digits. Now, if you keep on following the extensor digitorum down, there's another little one that extends out to the side, which is kind of like an expansion of the extensor digitorum, and that's called the extensor digiti minimi, right? So extensor digiti minimi will just be going to the little finger, whereas extensor digitorum goes to all four of the fingers. You can actually see those tendons start to branch out into four tendons. And then the next muscle across, which is kind of a large muscle that you can sort of see in people's forearms, and that is the extensor carpi ulnaris. Okay, so, and I can even do it down here. We had the brachioradialis, the extensor carpi radialis longus, extensor carpi radialis brevis, the extensor digitorum would be in here, extensor carpi ulnaris. You can't really see extensor digiti minimi as the little anconeus here. And that would be the end of the extensors. The next big muscle bulk that you can see next to those extensors is actually a flexor muscle. So then we're moving over to the flexor compartment. So we'll work our way there. So the first flexor, if we're starting in the middle of the elbow, all right, from the cubital fossa, we have the pronator teres. It's just a muscle that pronates. The next one is the flexor carpi radialis. So it's named like that because it flexes the carpals and it's on the radial side. And the flexor carpi radialis is usually the big tendon in your forearm. So that big tendon right here, that's the flexor carpi radialis. And then we have the palmaris longus. So you might just be able to see the palmaris longus here in this wrist. But palmaris longus isn't in everybody. Sometimes you have to do a very particular movement for it to stick out of the front of your wrist. But the palmaris longus, in this case, is this tendon right here. And it's sitting just below flexor carpi radialis. The next thing we have is the flexor digitorum superficialis. So the flexor digitorum superficialis kind of sit underneath here. You can see some of the tendons passing through here, and they will flex your digits superficially. So they don't flex the very end of your finger, they flex the middle of your finger. Okay, that's a flexor digitorum superficialis. You can see some of the tendons lying underneath here, right there. And then you have the flexor carpi ulnaris. Flexor carpi ulnaris would be this tendon right here. Okay, it's like the radialis, but it's more on the ulnar side. It doesn't stick out as much. And then if you go very deep, so if we go deeper anterior, then we have another big muscle group that has 4 tendons in its distal expansion, and that is the flexor carpi profundus. Right? So you have a superficialis that just attaches to the middle part of your digits, and the profundus, which attaches to the distal part of your digits, okay, your distal phalanx. And then we have the flexor pollicis longus, okay? This muscle here is a flexor pollicis longus. It helps you flex your thumb. And finally, the pronator quadratus. And pronator quadratus, sort of like the pronator teres, is like a singular muscle that attaches one of the forearm bones to the other forearm bone, the radius to the ulna, and it just sits in here. It's like a little wrist muscle anteriorly, and it sits underneath all of those tendons, so that's why it's kind of hard to find. In the cadavers, you can peel the tendons away and see it a lot easier. Now, I know that sounds like a lot, but we are going to learn this list of muscles, and through the labs, you are going to learn how to identify all of them. So the rest of the lecture, I'm going to go through each of the muscles that I just mentioned there in a little bit more detail so we can help understand it. Let's do it. But before we go through all the muscles, I'll just quickly go over some of the vessels and the nerves in the area. You won't need to be able to identify it for the exam, but it's good to know where these structures lie because we're going to be looking at this area. Yes, before we go through all of the muscles, we'll just quickly mention all of the nerves and the vessels in the area as well, just to orient you to some of the other structures that you'll be coming across. So first of all, superficial nerves and vessels around the elbow. You'll see that we have some large veins that come up from the forearm into the upper arm. Medially across the big forearm, you've got your basilic vein, and then that just courses between the biceps and the triceps as it runs up through the upper arm. And then laterally, you've got this cephalic vein, which then runs more anteriorly and laterally across the arm. Sometimes it squiggles across the biceps. So those veins are important because between them is a communicating vein called the median cubital vein, and that is the vein that people get blood out of. That's why people are always taking blood out of your elbow, because it's the vein that is contributed to by these two large veins here. So you'll usually be able to see them in some of the cadavers. If I've done the dissecting, you'll probably have some of them still in place. Medially, from a nerve perspective, you'll see the median and the ulnar nerve, again coming from that compartment between the biceps and the triceps, but then the median nerve courses anteriorly into the forearm, anterior to that medial epicondyle, and then the ulnar nerve courses posterior to that medial epicondyle. It basically goes through a little canal between the medial epicondyle and the olecranon of the ulna. And that is sometimes where it gets banged and it causes that buzz down your hand, and that's what some people call the funny bone, right? So that's the ulnar nerve there. From a lateral aspect, you can see the radial nerve just coursing laterally across that lateral epicondyle, and then it branches into a superficial and a deep branch of the radial nerve, and then that deep branch then branches into something called the posterior interosseous nerve. So you'll need to know the posterior interosseous nerve when you're talking about the innervation for some of the muscles of that posterior compartment of the forearm. The radial nerve technically ends right here at the elbow, and then it has its branches that you need to know. Well, you only need to know posterior interosseous. As they go down into the wrist, some of the structures you'll be able to see anteriorly are the radial and the ulnar artery. The radial artery is pretty exposed, and it can be pinched right against the radius, the flat radius, which is why it is an artery that you use to palpate the pulse. The ulnar artery, it kind of swims with all these other tendons and structures, so it's much easier. It's much harder to pin down and find a pulse. You can still do it, it's just a little bit harder. But through a similar region, you'll find the median nerve, which courses into the hand via the carpal tunnel, and then the ulnar nerve, which comes more across the ulnar side, and it also goes into the hand, but via its own little tunnel, the tunnel of Guyon. Yeah, so that's the structures you can see at the wrist. So these are the nerves that we're concerned with when we're looking at muscles of the upper arm, the forearm, and the hand. So there's the radial nerve, the median nerve, and the ulnar nerve. The radial nerve, it basically is active all the way through the arm. It innervates all the muscles of the back of the upper arm, so like your tricep muscles, and then it courses to the posterior compartment and innervates many of the muscles of the posterior compartment of your forearm. So that's why it's very active in the upper arm and very active in the lower arm. The median nerve, however, is lazy in the upper arm. It just is asleep and doing nothing and just bludging all the way until it gets to the elbow. When it gets to the elbow, then it actually starts to innervate a few of the muscles of the anterior compartment, so the front part of your forearm, and then it goes into sort of the thumb side of your hand. It innervates muscles down there. Likewise, the ulnar nerve, another very lazy nerve that takes a while to wake up. It does nothing in the upper arm, but then as soon as it passes the elbow, it'll only innervate two. It's still not completely awake. It'll only innervate two muscles of the forearm, but then it goes nuts in the hand. It basically innervates all the muscles of the hand, except for the few muscles that are innervated by the median nerve. Okay, so the ulnar, the median, and the radial nerve. You'll get to know them a little bit more as you understand the origins and insertions and innervations of the following muscles. Oi, do 10 sit-to-stands. All right. Now do 10 single leg sit-to-stands on each leg. How do you feel? Ready to learn? Thanks. Now back to study. Okay, so now we can dig into the muscles of the arm. We're starting with the triceps brachii, and then we'll go into the little anconeus in the posterior part of our elbow. So the triceps are the big muscles of the posterior arm. They're the prime extensors of the elbow. So yeah, they're really the agonists of elbow extension, the main agonists. The long head of the triceps does cross the shoulder, but it has a very weak moment over adduction and extension. It's not that strong in doing so. You have much larger muscles that can do that motion better for you. So yeah, primarily it's at their elbow extensors. The triceps, 3 heads, that's what it means. It's made up of a long head, a lateral head, and a medial head, which you can't really see here. The long head is the only one to attach beyond that shoulder, and it attaches to a little bump below the glenoid fossa of the scapula, and that bump is called the infraglenoid tubercle. All right, that's what it means. It's a bump below the glenoid, infraglenoid tubercle. So that's the origin of the long head. The origin of the lateral head and the medial head are on the posterior humerus, but their attachment site relates to this particular feature in the humerus called the radial groove. Now, if you look at the bone of the humerus, not the radius, the humerus, it looks like it has a twist mark, like someone's held the top and the bottom and they've twisted the bone a little bit. So it has this sort of groove that makes it look like it's twisted. And that groove is where the radial nerve actually passes. Okay, this is the radial nerve depicted by this chick in a yellow swimsuit throwing up the shuckers, riding a surfboard because she's rad, and playing the saxophone because she's just grooving. And that's the radial groove passed through by the radial nerve. That feature helps you understand where the other two muscles of the triceps originate. So superior to the radial groove on the posterior humerus, you have your lateral head, and inferior to the radial groove, you'll have your medial head. Yeah, so now you know all of the origin for your triceps brachii. And the insertion is just simply the olecranon of the ulna, the tip of your elbow. Right? They attach down there via the triceps tendon. The next muscle is the anconeus, which is a much smaller extensor of the elbow. So it does extend the elbow, but it's not as strong as the triceps in doing so. And it just attaches to that lateral epicondyle, or the posterior aspect of it, and then to the olecranon and the proximal end of the ulna, basically before it goes down to that ulnar ridge. So yeah, that's where it originates and inserts. It's quite a small triangular muscle. So its primary role is probably more maintaining extension when you're putting weight through it. So it sometimes appears to be a distinct muscle in other animals that are quadrupedal, that are weight bearing a lot more. But it plays more of an important role in humans as a stabilizer when we're crawling. See, in infancy, in that relatively short period where we are sort of quadrupeds. That's where the anconeus really comes into its own and does a lot for us. But otherwise, it's maybe more of a stabilizer of the elbow, and it can maybe it may prevent the elbow going into abduction, right? So it prevents too much abduction of the elbow, especially as we pronate our forearm. But that's to learn about later. It's mostly just a stabilizer, but it can extend the elbow. Okay, so now we're on to the elbow flexors, so the anterior compartment of the upper arm. We'll start with the biceps brachii. It's the most superficial and prominent muscle in the region. The biceps brachii, two heads. It has a short head here, which attaches to the coronoid process of the scapula, and we have the long head, which actually has this long, thin tendon, and that tendon courses up through what you can call the bicipital groove of the humerus, or the intertubercular sulcus, because that's the lesser tubercle and that's the greater tubercle, and it's the intertubercular sulcus or ridge. And then that tendon goes above the humeral head and attaches to the top of the glenoid cavity at a little bony feature called the supraglenoid tubercle. It's a little bump at the top. It'll also attach to the labrum, that's why it's involved in a lot of labral pathology, but mainly it's attached to that supraglenoid tubercle. You remember that the triceps attaches, or the long head of the triceps attaches to the infraglenoid tubercle, while the biceps, long head, attaches to the supraglenoid tubercle. All right? Makes sense. Now, both of the heads, they converge into the same muscle belly, and then they will form a singular biceps tendon and attach to a prominent feature of the radius called the radial tuberosity. So if you look at the radius, you can see that radial tuberosity. It's pretty easy to see on the proximal end of the bone. Now what it does is, because it attaches to the radius, remember the radius is the bone that moves in pronation and supination. So that means if you're in a supinated position and your radius is tilted over your ulna, it curls the bicep tendon underneath. And when the biceps contracts, it can uncurl the radius, which creates a supination position, right? So the biceps brachii supinates as well as flexes and extends. Now, I'll show you through complete anatomy what that actually looks like, because it's a bit easier to understand. So here we go, here's complete anatomy. I can click on the biceps, and as you can see, if I click the motion tab, info tab will tell me everything about it, but the motion tab will show me some of the movements. I can add a supination. So if I zoom out, or maybe zoom in a little bit, this is where the biceps are a bit stretched, but then when it contracts, it helps unwind and face the palm towards, right? There you go. Because that tendon right underneath, attached to that radial tuberosity, it basically just unwinds the bone to create supination. And then, of course, it does flexion extension as well. Flexion extension. There it is. All right. And as you can see, if I look on the medial aspect, the biceps has a really good moment arm over the axis of rotation. Really, it's the tendon inserts far away from the axis, which means it has a really good ability to generate rotational force. But now we're going to look at the next muscle just underneath it, which is the brachialis. So here we have the brachialis. So it's that deep brachial muscle or arm muscle, just deep to the biceps brachii. And its main job is just to purely flex the elbow, because it just goes from the distal half of the anterior humerus straight to the ulnar. So it crosses really the main elbow joint. It doesn't mess around with pronation and supination. It's just a straight elbow flexor, which is why it's so good at what it does. Yeah. So it'll attach to the ulnar, so to the coronoid process of the ulnar and the tuberosity of the ulnar. So it doesn't touch as far down as the biceps. It doesn't have as much of a moment arm. But then the next muscle across is the brachioradialis. So it will attach from the distal humerus right above that supracondylar ridge of the lateral epicondyle. So the superior 2/3 of the lateral epicondyle. We'll go through what that is in a bit, and then it'll attach to the distal lateral radius. So some people think it attaches beyond the wrist. It doesn't. It just attaches across the elbow, but it has a lot of its muscle mass in the forearm. So it's just an elbow flexor. So in terms of innervation, the musculocutaneous nerve, it's the main nerve that innervates the front of the arm. So the musculocutaneous nerve innervates your biceps brachii and your brachialis. But because your brachialis is sort of very deep, it'll also get a branch from the radius coming from behind. And because the brachioradialis is also sort of somewhat deep and a little bit more lateral, it gets the radial nerve just solely by itself, along with some of the other muscles at the back of the forearm. So biceps is musculocutaneous nerve, a distal branch of the brachial plexus, and brachialis is musculocutaneous and radial, whereas the brachioradialis is just radial. So just to give a bit of a shout out to that brachialis, people don't give it much appreciation. You can see the brachialis sometimes, but not very often. It's overshadowed by that biceps brachii that sits on top of it. But here you can see in Arnie just a little pop out of the brachialis there, and you can see like a bit of it there. This is cross section of the upper arm, and that whole area is brachialis. So when it does grow large, it actually helps push the biceps brachii out more. And by doing that, it actually, through hypertrophy of the brachialis, it pushes that biceps brachii away and can increase its moment arm over the joint, as I was mentioning before. It already had a great moment arm, but with the help of a hypertrophied brachialis, it actually creates a larger moment arm. So a strong brachialis can create an even stronger biceps, or a biceps with greater mechanical leverage, in this example of a straight elbow. So it's a muscle that people don't often appreciate, but you should, because it's a champ. So the elbow flexors. How do they function? Well, they basically all help you flex the elbow, but depending on where that elbow or the forearm is in space, different muscles will be activated. So in a supinated position, remember the biceps supinates, the biceps will help flex the elbow a lot better in a supinated position, so with the palm facing you. In a neutral position, the brachioradialis starts to work a lot more. Okay, so you can see the brachioradialis pop out a lot more because you're aligning its origin and insertion a lot better, and you're taking away a bit of the biceps. And then in more of a pronated position, both the brachioradialis and the biceps brachii are sort of taken under a bit of, or they're pulled a little bit, so then you'd be using more your brachialis. So supinated position would be biceps, neutral would be brachioradialis, and then more of a pronated position will be brachialis. Yeah? And this is just some of the pictures of the origin and insertion. See brachioradialis, it sits right above the ridge of the lateral epicondyle, that superior third of the ridge above the lateral epicondyle. And then it just has this little attachment site to the distal radius, again, not going beyond the elbow, beyond the wrist. And brachialis, big dumb muscle, just goes straight from one bone to the other, has a massive origin on the humerus, and then attaches straight to that ulna right there. Yep. So those are the elbow flexors. So this is just a slide demonstrating open and closed chain in context of the elbow. So we know the elbow muscles can flex or extend the elbow, but they can do it in different situations. So in this situation, which is an open chain, this guy's holding onto a free weight, so a barbell here, and he's performing a bicep curl or an elbow flexion movement. The muscle, which just wants to contract and just wants to bring origin close to insertion, is trying to find one point of stability and move the other point towards that point of stability. And in this case, where the biceps attach, their origin, so where they come from the scapula, is the point of stability. So that's why his shoulder girdle isn't moving and his trunk isn't moving, but the insertion of that muscle, so the radius and the forearm, is moving. So the stable point is the proximal part at the origin, and the moving point is that distal part of the forearm. This is an open chain. The distal segment is moving around. In contrast, this is a closed chain. So the guy is holding onto a chin-up bar, and now the forearm and the radius has become the stable point. So now the biceps, when it contracts, it's contracting from that stable point and moving the moving point, which would be this guy's shoulder and his scapula and eventually his trunk. So his trunk and scapula is moving towards the stable point of his forearm. So it's similar, it's almost the same movement, except a different part of your body is moving. In this case, the forearm is moving, but in this case, the whole body is having to move, okay? So this is a closed chain situation. These are two other examples of closed chain in which somebody is trying to extend their elbow using their triceps brachii. So in this position, somebody is doing a dip out of a chair. So the chair is attached to the floor, so it's stable, and the forearm is attached to the chair. So the forearm is the stable point, and the body is moving relative to the forearm. So that's a closed chain exercise. This is pretty much the same deal. Person's holding onto the wall, so the forearm is on the stable point, and they're doing a wall push-up. Same thing would be true of a regular push-up. The body is moving relative to the forearm. So that's becoming the point of stability. So both of these are closed chain exercises. And this would be an open chain exercise for the elbow. So as you can see, the trunk is stable, and the scapula is getting stability off that. And then the distal segment, so the forearm and the hand and the fingers, they're all moving off that stable segment. So in this case, that's an open chain. So any kind of throwing movement is an open chain exercise. We tend to do more open chain things with our upper extremity, and we tend to do more closed chain things with our lower extremity. That's because our lower extremity tends to be attached to the floor more than our upper extremity, unless in the case of hanging or climbing or push-ups. Yeah. Okay, so now we're finally into the forearm. So the true forearm muscles. This is going to be fun. We've done a little bit of brachioradialis, okay? So at the very top of our forearm, or the most radial muscle on our forearm, and we're going to start to move down, so in more of an ulnar direction. So as you can see here, this is the brachioradialis. It hasn't been highlighted, attaching high up to that supracondylar ridge. But the next muscle down is the extensor carpi radialis longus. Extensor, carpi, which means the wrist, the carpals, radialis, because it's on the radial side of the forearm, and longus, because, like the brachioradialis, it attaches high up to that supracondylar ridge. It actually attaches to the lower third of the supracondylar ridge, okay? So not like these other suckers who are attaching to that lateral epicondyle. It is a bit more privileged. It gets to attach to the ridge a bit higher up, okay? Just like the brachioradialis. So the extensor carpi radialis longus's insertion is all the way down to the back of the hand. It wants to find a nice little point to hold on to the back of the hand so it can help you pull your wrist back into extension. And what it found is this lovely base of the second metacarpal. Okay, so that's the base. It's like your index finger, that metacarpal, the base. That's where the extensor carpi radialis longus will attach. Okay. And then he has a little sister, the extensor carpi radialis brevis, just a little bit shorter, unfortunately, because it doesn't attach high up to the supracondylar ridge. It just goes right to that lateral epicondyle via the common extensor tendon. You can see that white part here. They all kind of form the same tendon called the common extensor tendon, and that tendon attaches to the lateral epicondyle. So that's why we say lateral epicondyle via common extensor tendon. And then extensor carpi radialis brevis follows her big sister all the way down to the back of the hand. And she also wants to insert somewhere to the back of the hand to help you extend your wrist, because it's in her name, extensor carpi, on the radial side. But the base of the second metacarpal has been taken, so she just goes to the base of the third metacarpal. So second is longus and third is brevis. Yeah? The next muscle across is the extensor digitorum. So again, just attaching to that lateral epicondyle via the common extensor tendon, and it comes down and breaks into 4 tendons. Now, it's also called the extensor digitorum communis, and that's just because it forms a community of tendons, 4 tendons as it branches out. And those branches can be higher up or they can be lower down. In this case, they're just above the wrist, just proximal to the wrist. Yeah, this has a lot of variation. But yeah, it branches into 4 tendons, and they will attach to the base of the middle phalanx and the base of the distal phalanx. All right, so from here to here. They won't attach to the proximal, just the middle and the distal. They attach to both of those bones to give you a little bit more leverage and a little bit more strength for extension. Okay, so you're not just extending from here, but you're also extending from the middle of your finger. Okay, so it gives you a bit more strength for extension. Now, in terms of nerves, we had the radial nerve coming down the back of the upper arm here, and then as it curls around the radial head, it splits into some divisions, into a deep radial nerve and then into a posterior interosseous and an anterior interosseous. But you just need to know that pretty much after that lateral epicondyle, it splits into the posterior interosseous nerve. It's named that just because it runs posterior to the interosseous membrane in that forearm. Yeah, so the posterior interosseous, it will pretty much innervate all of the muscles of the extensor compartment, so the back of the forearm. But because the radial nerve only branches here, the muscles that attach higher up, they're just innervated by radial nerve. So your brachioradialis and your extensor carpi radialis longus, they're just radial nerve. But down here, then we actually have the posterior interosseous. Extensor carpi radialis brevis technically gets a deep branch of radial, but mostly it's all from the posterior interosseous nerve. So brevis and extensor digitorum, posterior interosseous. You'll hear me say posterior interosseous a few more times. Oh, this is just a nice picture, also illustrating those muscles that we went over. This is Mike Tyson, and he's showing off the insertion of the extensor carpi radialis longus, which is right here, the base of the second metacarpal, and he's also showing off brevis, the base of his third, so kind of the base of his middle knuckle, right there. And here you can see that would be longus on the second, brevis on the third, and then extensor digitorum on the middle and the distal phalanx there. Cool. Okay, so now we're going a little bit deeper and a little bit more to the ulnar side. So the posterior compartment, a little bit deep, we've got, starting with the extensor digiti minimi. So the next one across from the extensor digitorum is the EDM, the extensor digiti minimi. Just like all the other muscles, it'll attach to that lateral epicondyle of the humerus via the common extensor origin, right? And it will then course all the way down and basically attach to the extensor expansion of the little finger. So in reality, it does just like the extensor digitorum attach to the middle and the distal phalanx, but it attaches more to kind of the fascia at the back of the finger, so extensor expansion. And extensor digiti minimi just extends the little finger. It gives you a little bit more dexterity on the edge of your hand for your little finger. Surprise, surprise, innervated by posterior interosseous nerve. Extensor carpi ulnaris, so that's the next one across. So it's the muscles closest to that to the ridge of your ulnar, and it's the extensor carpi, so it extends the wrist. So it has to attach down beyond the wrist. Now its origin is the lateral epicondyle via the common extensor origin, and its insertion is the base of the fifth metacarpal. So remember, the extensor longus, radialis longus, was the base of the second, radialis brevis was the base of the third, and then ulnaris, extensor carpi ulnaris, is the base of the fifth. The only thing we're kind of missing out in is your ring finger base. It's got nothing. Yeah. So, also innervated posterior interosseous nerve. So these muscles so far all are just extending the wrist, and the digiti minimi is extending the little finger. Okay, now we have the supinator. You probably can have an idea what the supinator does, but it originates from the lateral epicondyle, the supinator crest, and the supinator fossa of the ulna. So it comes from both the humerus, the lateral epicondyle, and the ulna. Okay, so it gets the attachment of both of those bones, and then it will insert into the proximal 1/3 of the radius. So basically, all the way up the top of the radius, 1/3 of the whole bone. Yeah, and its job is to supinate. Okay, it basically curls that radius over the ulna and allows for that supination position. It's not a strong supinator like the biceps brachii, but it's closer to the joint, so it's actually more of a stable supinator, right? It makes sure the joints go directly in the position they're supposed to be going. Yeah, so you could also say it stabilizes the joints as well as supinates. And it is innervated by the posterior interosseous nerve. Now, these muscles, not the ulnaris is easy to find, but the supinator and extensor digiti minimi are a bit deep, so you're going to have to sort of dig between muscles to find them. Digiti minimi is right underneath extensor digitorum communis. It's like right underneath it pretty much, and it almost looks like it is one of those muscles. But then supinator is behind, and you can see I've actually taken out extensor carpi radialis brevis. It's basically between sort of brevis and extensor digitorum. So I've taken out brevis and digitorum here for you to see it. Cool. And here's some more lovely pictures just to demonstrate the origin and the insertion of these muscles. Here's the supinator here, attaching to the ulna's supinated crest there. Lovely. And that lateral epicondyle. And then it's coming right down and attaching to the superior 1/3 of the radius. Here we have the extensor digiti minimi, weird little muscle, only going to the little finger. So she's using it right there just to give a bit of a touch of class to her tea drinking. Yeah, again, it's just there for a little bit more dexterity of your little finger. And then we have the extensor carpi ulnaris there attaching to the base of the fifth metacarpal. Okay, so now we're digging even deeper into the posterior compartment. There are layers to this. So we're a bit deeper in the posterior compartment. And now we're looking at all of the muscles that actually attach into the forearm themselves. So they actually, we're taking away all of the muscles that have attached to the lateral epicondyle, stripped away, gone. Now we're just looking at the muscles that attach further down the forearm, and then they go into the hand and the fingers. So let's start. So you can see supinator just there, lovely supinator. But just below it, distal, we have the abductor pollicis longus, the abductor pollicis longus. Now, I might just quickly mention how the thumb moves. So the fingers move in this plane, but the thumb moves in that plane. fingers, thumb. The thumb moves in a different plane to the fingers. That's why they call it the opposable thumb. Sort of opposes the fingers. So flexion of the thumb is actually when the nail bows down. So I'm looking right on top of the nail. Bowing down is flexion. And as it arches up, that's extension. If the nail moves along its plane in towards the hand, that's called adduction of the thumb, or the pollex. And then as it brings it out, it's abduction, abduction of the pollex, or the thumb. Pollex means thumb. So now we know that, we'll be able to understand these muscles a little bit better. So the abductor pollicis longus, it attaches from both the ulna and the radius and the space in between, which is the interosseous membrane. Particularly, it goes from the proximal half of the ulna. Okay, so this is the ulna, the upper part of the ulna, and the middle 1/3 of the radius. Okay, middle 1/3 of the radius, proximal part of the ulna, and the interosseous membrane in between. And then it will come down into a tendon. And it's not so easy to see this in your hand. It's actually kind of subtle, because it really passes down the radial side of your wrist. And it does that so it can attach to the base of your first metacarpal. Okay, on the radial side or on the lateral side. It doesn't want to attach to the back side, because that would make your thumb go backwards into extension. It really attaches to that lateral side or that radial side, so it can pull your thumb out into abduction. Okay, that's why it's the abductor pollicis longus. Yeah. So remember our other extensor carpes, they all attach to the base of metacarpals. This is also attaching to the base of metacarpal, but bringing your thumb out. So that's the abductor pollicis longus. You can't really see it, but it inserts sort of into that area there. But you can see its big muscle belly. The next muscle that we go across is lying a little bit deep, but this is the extensor pollicis brevis. So it's a muscle that extends the thumb, and it's a bit shorter than the other version. Okay, so the extensor pollicis brevis, it comes from the radius and the interosseous membrane. So it just attaches to the posterior part of the radius, sort of the distal half, and then the interosseous membrane, but it doesn't go all the way to the ulna, unlike the abductor pollicis longus. Okay. So extensor pollicis brevis then comes down and it inserts to the base of the proximal phalanx of the thumb. Okay, so it doesn't go just to the metacarpal; it goes to the actual phalanx, the base of the proximal phalanx. Remember, the thumb only has two phalanges, a distal and a proximal, and it goes to the base of the proximal. Okay, so it helps you extend your thumb mostly at this joint, at the metacarpophalangeal joint 1, MCP. Yeah, you can't see it very well here. You can see the muscle belly coming through, and then you can see its tendon sheath at least, and then you can see it attaching right there. Yeah, okay, the tendon sheath makes it harder to see. So it slips into that white tendon sheath and attaches to the base of that proximal phalanx there. Okay, the next one, extensor pollicis longus. So it doesn't go from the radius. The extensor pollicis longus instead comes from the middle 1/3 of the ulna and the interosseous membrane. So the longus is this muscle here. It comes from ulna, but the brevis comes from radius, and both of them attached to the bit of the interosseous membrane. It's going into its tendon sheath there, and as you can see, it attaches all the way to the distal phalanx. Okay, that's why it's the longus. The brevis only goes to the proximal, but the longus goes to the distal phalanx. Okay, they really both work together to help you extend your thumb or bring that nail upwards. And finally, we have another deep muscle called the extensor indicis, or indicus, you can also call it. And that is a muscle that helps you extend your index. So remember how we had a digiti minimi, extensor digiti minimi? We also have a separate one for your index finger. So it's not just the extensor digitorum doing it. We have a bit more dexterity of our index and our little finger, which is why we can do that easily. So the extensor indicis, it comes from the ulna, or the posterior surface of the distal third of the ulna, and a bit of the interosseous membrane. And it goes to the extensor expansion of the fingers. So remember, digiti-minimi just went to the extensor expansion, and so does indices, extensor expansion. From a nerve perspective, you'll notice posterior interosseous, posterior interosseous, posterior interosseous. They're all innervated by the posterior interosseous nerve, which is actually coursing posteriorly to the interosseous membrane back there, which a lot of these muscles are attaching to, so it makes sense that they're getting innervation. This is a nice cadaveric picture of some of those muscles. You can't really see the abductor pollicis longus very well here, but you can see the extensor pollicis brevis tendon and the extensor pollicis longus tendon. Yeah, just there. And it kind of forms a little sort of hole in the radial side of your wrist where you can sort of find your scaphoid in there. But yeah, those are the two tendons that are quite prominent in you at the back of your thumb. Here's a nice picture of it. So first of all, that would be the abductor pollicis, because it goes to the base of your first metacarpal. Then we have the extensor pollicis longus, because it goes to the base of your distal, and it comes from the ulnar. Then we have the extensor pollicis brevis, because it goes to the base of the proximal bone of your thumb, and then it goes to the radius, also interosseous membrane. And then we have the extensor indicis here, which is ulnar, interosseous membrane to extensor expansion. And here's a picture of a thumb where you can notice a little bit of those muscles. So that's pollicis longus, again, attaching to the base of the metacarpal. I always pause when I'm saying metacarpal just so I don't say metatarsal. I'm doing pretty well so far, so apologies for the pause. And then we have the brevis attaching to the base of the proximal, and then we have the longus attaching to the base of the distal. Yeah, and you can see some of the flexor tendons in here. Yeah, flexor carpi radialis. Now, and that's probably the cephalic vein coming through there. Yeah. Anyway, that's some of the deep muscles of the extensor compartment. So extensor function. So extensor muscles aren't super strong. As you can see, they're pretty stringy. They don't have great leverage as they attach to these base of the metacarpals. Okay, so they don't have a lot of leverage. Yeah, so extension of the wrist, extension of the fingers isn't particularly a strong motion, but they're better at actually stabilizing the wrist in that position. So, for instance, Roger Federer here, one of the greats in tennis, he's using his extensors very well to keep his wrist rigid as he performs a backhand. So it's not making his wrist extend, it's more making sure it doesn't flex under impact, okay? It's stabilizing it in an extended position. But because they're not so strong, these muscles, they're actually very good at placing your fingers in space. So lifting your fingers and orienting your fingers to do things like receive a ball, or lifting your fingers to then reposition themselves to play piano. Okay, so you can see extensor muscles working quite a lot when people are playing instruments, because it's actually good for intricate motion. The flexors are more for pressing down and for a bit of power. The extensors are more for placing your fingers in space, or your wrist. Okay, so now we're on to the anterior compartment. We're leaving the extensor compartment behind, and now we're coming more into the front. These are larger muscles because they will help us with wrist flexion and finger flexion. So for grip, which is a lot stronger movement, we use a lot more power with this. So yeah, they will be a bit larger. This is the anterior part of our forearm, right? The forearm's facing forwards. We can orient ourselves because this is the biceps brachii and its tendon coming down into this pit of the elbow, or the cubital fossa. And we can see our old friend here, the brachioradialis. So we're going to start from that radial side and then move down in ulnar direction to try to muscles. So the first muscle that we come across is the pronator teres. As you can imagine, it is a muscle that helps you pronate your hand, okay? Turn your palm down. I am a pro, don't worry about it. Pronator teres. its origin is a bit higher up than the other flexors because it doesn't just attach to the flexor, the common flexor origin or the medial epicondyle. It attaches to the supracondylar ridge of the medial epicondyle. So the medial supracondylar ridge. That's why it attaches a little bit higher up. And it'll also attach to the medial aspect of the coronoid process of the ulna. So it attaches to the humerus by that medial supracondylar ridge and to the ulna before it then courses down and attaches to the radius, pretty much the middle third of the radius, okay? It doesn't do it very much justice in this in the complete anatomy. It kind of looks like a small muscle, but actually it's a bit larger muscle, and it attaches like right to the middle of the radius, right? The middle portion. So you can see here, that's the distal radius, that's the proximal radius. It'll attach somewhere in the middle there. So it actually kind of goes a bit longer than some people think. And it's sort of the homologue to the supinator. So remember the supinator at the back, it came from the lateral epicondyle and the supinator crest and part of the body of the ulna. So it went from humerus and ulna to the radius to help you supinate. The pronator teres does the same kind of thing. It attaches from the humerus, the supracondylar ridge, and the ulna via the coronoid process, and then it goes to the radius. Okay, so a large origin, and then a singular insertion. Okay, so they're kind of very similar muscles. They're just both toying on the radius and pulling it in different directions. So that's a pronator teres. Innervated by the median nerve. So let me introduce you to the median nerve in the anterior compartment. It will pretty much innervate every muscle in the anterior compartment at the front of your forearm. There's some muscles that will get some innervation by the ulnar nerve, but they're more muscles that are on the ulnar aspect of the forearm. Okay, there's only really two of them. So, pronator teres, median nerve, easy. The next muscle we have is the flexor carpi radialis. So it's a muscle that flexes the carpes, and it's on the radial side of the forearm. Now, the flexor carpi radialis, it's got a very common insertion to the common flexor origin, or the medial epicondyle, and it comes down and it will attach to the base of the second and the third metacarpals, okay? So it attaches to two bones here, and that's because when we looked at those extensor carpi radialis longus and brevis, those two of the muscles, the longus attached to the base of the second, and the brevis attached to the base of the third. But flexor carpi radialis, he is just taking it all on himself. He's like, I don't need two muscles to do this. I'm big enough to do it myself. So that's why he attaches to the base of the second and third himself. All right, all by himself. So it's pretty much very similar to the posterior aspect. They're attaching to the same areas, just on the palmar part of the hand. Again, median nerve, easy. Next one is the palmaris longus. So you can sort of see it tucked away here, palmaris longus, and you can mostly identify it by its long, thin tendon that runs very medial to the wrist. Now, if you were to flex your wrist and have a look at the big tendons that pop out, the biggest tendon is actually flexor carpi radialis. Okay, because remember, it has those two little insertion sites. It's a pretty big muscle, so it has a really big tendon at the front of your wrist. If you can sort of extend your wrist a little bit and keep the fascia at the front of your palms tight, like if you can pull it tight and extend, you might just be able to find a central thin tendon, and that would be the tendon of palmaris longus. I'll go into it in a little bit. Not everybody has palmaris longus because it isn't super useful, but you can identify it by a thin muscle in the very middle part of your wrist. It's not radial, it's not ulnar, it's right down the midline. It's innervated by the median nerve, and it doesn't actually attach to bones. It attaches to the palmar aponeurosis and the flexor retinaculum. So the flexor retinaculum is the roof of the carpal tunnel for all the structures to come through, and the palmaris longus, it might help lift the roof of the carpal tunnel a little bit, but mostly it brings tension to the underside skin of your hand or the fascia of your hand. otherwise known as the aponeurosis, the palmar aponeurosis. It actually tightens your hand that would allow for better grip in more of a hook grip position, or sort of like an open hand grip position, which again we don't really use very much, which is why it's not so common. Well, it's common, it's just not in everybody. So that's the palmaris longus. The next one is the extensor digitorum superficialis. Now this is a pretty big, strong muscle, okay? It helps you with hook grip, okay? Holding things like this, which you do when you're like hanging your shopping bags. People tend to hold it like that instead of your whole hand. You know, your hook grip is actually a pretty strong grip, okay? So because of that, the extensor digitorum superficialis is afforded quite a large origin. Its origin is the medial epicondyle of the humerus, just like all the other muscles in the area, but it also gets the part of the ulna, the sublime tubercle of the ulna, and the anterior border of the radius. So it gets the humerus, ulna, and radius as its origin before it courses down and splits into the 4 tendons that will insert into the fingers. Okay, so big origin. The insertion will actually be to the base of the middle phalanx. Okay, remember the extensor digitorum? It went to the base of the middle and the distal, right? The superficialis, it just goes to the middle. Okay, so it can help you with sort of more that hook grip. And again, median nerve, easy median nerve. And again, it goes to the 4 fingers, not the thumb. Yeah, fingers 1, 2, 3, and 4. Yep. Flexor carpi ulnaris. So now we're on the most ulnar side of these superficial muscles. Again, medial epicondyle of humerus via the common flexor tendon. But because it's a large muscle, it also attaches to 2/3 of the body of the ulna and the olecranon. So that's the olecranon. That's the medial epicondyle. It like attaches to the olecranon and like does a loop to the epicondyle, like it forms a little window here, and then attaches to a bit of the body of the ulna. And it's like it's a pretty big muscle. Like it's a large, chunky muscle in your forearm. The other ones are a bit stringy, but flexor carpi ulnaris is kind of like a bulky muscle. Yeah. Again, complete anatomy don't quite do it justice with its size. Maybe you can see a little bit more posteriorly. Because you can see it's on the other side of the border of the ulna right here. It's like basically that big chunky muscle. It gets the ulnar nerve because it's more on the ulnar aspect of the forearm. Okay, unlike the other muscles, it just is a muscle on its own, gets the ulnar nerve, but it's a big muscle, so it deserves its own nerve, you know? It also deserves a very complicated insertion. So the origin, medial epicondyle of the humerus, body of the ulna, sublime tubercle of the ulna as well, but it will attach to 3 bones in the palmar aspect and of the ulnar aspect of your hand. So if you feel this part of your hand, you can feel a few bumps coming out. There's the pisiform, which will attach to, the hook of the hamate, which is just a little bit distal, which will also attach to, and then it'll attach to the base of the 5th metacarpal. All right, remember extensor carpi ulnaris attached to the base of the 5th metacarpal. Flexor carpi ulnaris attaches to the base of the 5th metacarpal as well as these 2 other carpal bones, pisiform and hook of hamate. Yeah, cool muscle. Yes, so this is just on the palmaris longus. So I mentioned before it is absent in some people, so there's agenesis in some populations, and that can range between 1.5%, where it's absent, up to 64%. So in some populations or communities, the majority of people might not have this palmaris longus, okay? So it just varies around the world. And this is a great picture of it. This is someone trying to flex their, or put tension on their palmar aponeurosis by posing their little finger and their thumb, and then you can see it pop out in a person who has it, and not at all pop out in a person who is absent. But you can rest assured that this guy, he still has it. So the gibbon and all of the other brachiators, all the other animals that still climb using their hands and using this open hand hook grip on like a big sort of trunk, they're still using it quite a lot, okay? And it's much larger in these animals, okay? So he's using his palmaris longus on the regular. Look at him. What a cutie. Alright, so here's some lovely pictures of those muscles we went over. We've got the pronator teres here, and you can see it really does attach to the middle part of that radius. Yeah. We have the lovely flexor carpi radialis, and you can see its insertion to the two bones, so both the base or the palmar base of the second and the third metacarpal. Over here we've got the palmaris longus and its lovely insertion to the palmar aponeurosis. Okay, so a big kind of broad fan to the underside of the skin of your hand. Yeah, we've got the old flexor digitorum profundus. Yeah. No, sorry, superficialis. What am I talking about? The superficial flexor. We can see it's coming from the medial epicondyle. We can see it's coming a little bit from the radius, and it's also coming from the ulna. So a really big origin site, and then it's just then attaching to the middle phalanx of the fingers. Okay? There are those pictures of the origins. And then we've got the old flexor carpi ulnaris, so medial epicondyle. You can even see that little window there. See that window? And then it's coming back and it's attaching to the olecranon process. It allows that window for nerves and vessels to come through. What a considerate muscle. And then it comes down and actually has 3 insertions there to the pisiform, the hook of the hamate, and the base of the 5th metacarpal. So far so good. Okay, so now on to the deep anterior compartment muscles. As you can see, we've taken all of the muscles away from the common flexor origin. Okay, they're all taken away, and now we're going into the ones that lie underneath it and actually attach to the forearm and go down into the hand. So the first muscle we can see here is the flexor digitorum profundus. Now remember, we had a flexor digitorum superficialis in the more superficial compartment. So superficial means on the outside or more exterior. Superficial person only cares about the outside, you know what they look like. But profound means on the inside, or you're deep, or you're, deep in thought. And the flexor digitorum profundus is definitely an important deep thinker. It's a very strong muscle, just like the superficialis, but it has a few special features. So let's go through it. We've got the flexor digitorum. It attaches to the coronoid process of the ulna and the superior 3/4 of the ulna. Okay, it says superior 3/4 and anterior and medial surface of the body ulna, but you can just say the superior 3/4. Okay, so it has quite a large attachment to the ulna. All right, all the way from the coronoid process to the distal third. Yeah, so the distal quarter rather. So yeah, really long origin. And then it forms these tendons that will go into the fingers. And the tendons, you'll actually notice, are quite broad. They're a bit broader when you have a look at it in the cadavers than the superficialis. Yeah, they're very kind of broad tendons. They go deep underneath the carpal tunnel, and then they'll attach all the way to the distal phalanges, okay, of fingers 2 to 5. All right? So where superficialis attached to the middle phalanx, profundus attaches to the distal phalanx. Okay? And the special feature for this muscle is that it gets innervated by both the median and the ulnar nerve, because it's very much on the ulnar aspect. So it's the only muscle in the forearm, really, that gets that dual innervation of two nerves. Okay? So it gets the ulnar and the median nerve. Great question for the exam, because you get 2 points for one muscle for the innervation. Yeah? Okay, so the next muscle we have here is the flexor pollicis longus, because we're on the anterior aspect. We need a muscle that helps flex our thumb. So this is a long muscle from the forearm, and it's coming down into the thumb. It attaches to the interosseous membrane and the radius. So remember, the thumb is on the radial side of your forearm, so it makes sense that the muscle comes from the radius. So as the radius rotates around, it basically stays in the same orientation with the thumb, right? If it attached too heavily to the ulnar, every time you move, it would sort of tighten and lengthen the muscle. But instead, because it attaches to the radius, it means the thumb doesn't have to move so much unless you want it to move, right? It allows for a bit more control of the thumb. Some texts say it does attach to the ulna slightly, but generally it just attaches to the radius. The radius of the interosseous membrane, and it goes all the way to the palmar base of the distal phalanx. And remember, the thumb only has a distal phalanx and a proximal phalanx. Only two bones, and then the metacarpal there. So it touches all the way to the end at the front, and it flexes, and it's innervated by the median nerve, an anterior compartment muscle. Finally, we have the pronator quadratus. So the pronator quadratus is sort of this wristband muscle right at the front of the distal part of your ulna and your radius. It says here the anterior aspect of distal 1/4 of the ulna and distal 1/4 of the radius. I'm happy with just the distal radius and the ulna. And I'm sure you're asking which one's the origin and which one's the insertion. Well, the origin is usually the stable point, right? And in pronation and supination, the ulna is the rigid strut from which the radius rotates over, okay? So the ulna acts as the origin and the radius acts as insertion. So it's attached to the distal anterior portion of the radius and the ulna. Yep, and it just gets the median nerve as well. Boring median nerve. Here are some nice, lovely pictures of the flexor pollicis longus. So yeah, in this text, they actually have said it attaches slightly to the ulna as well. But in most cases, we consider it just attaching to the radius and the interosseous membrane and then the base of the distal phalanx of the thumb. Here we've got the pronator quadratus, this cool little like wristband, pretty trendy, on the anterior aspect. And in this case, it actually is quite large. So you probably could say it is the distal quarter of the anterior surface of the radius of the ulna. Yeah, I'd accept that. But yeah, distal quarter, looks good. And here we have the flexor digitorum profundus. What a smart muscle right there. Real profound because it gets dual innervation, ulna and radius, and then it goes all the way to the tippies of the fingers. Yeah? Really big origin. Look at that. It goes coronoid process and right down the ridge of the ulna. Right down the body of the ulna. Cool. Big muscle. Big muscle in a small compartment. Here is some finger flexor function. Flexors of the fingers and the wrist. So generally the fingers, they can flex, but that also is accompanied by wrist flexion because the finger flexors cross the wrist as well. So going from here to here would be finger movement, and then of course that would also be wrist movement. So your flexor carpi muscles would be coming in there, your radialis and your ulnaris. All your fingers flex, and they can oppose your thumb flexion too to actually squeeze things and destroy this can. But they can also work individually to actually help with different things. So here, a thumb flexor is pushing against this finger to open a key, while the other finger flexor is actually holding up a coffee cup. So you can be quite dexterous with how you use these finger flexors, all right? They don't always have to be working in unison. Sometimes they work in isolation. And then when we talk about flexor digitorum superficialis and profundus, this is important for climbers because climbers train different grips, in which case they'd be using slightly different muscles in their hand and their forearm. In this case, there's a crimp grip where they're actually able to curl their middle phalanx and their distal phalanx over the hold, in which case they can use both superficialis and profundus. But when the crimp gets even smaller and you can just get the tips of your fingers over the hold, then you're mainly just using profundus to hold you in that position. And for some people, they don't have the strength to support their body weight like this. So that's why climbers will have to train that crimp grip to really work that flexor digitorum profundus. And that's the end. That is the end of the forearm. What some people consider the hardest part of anatomy, you've just gotten through. I mean, you still need to like retain it and, you know, do the labs and the pracs and stuff, but still, you've gotten through a big chunk. So if you have trouble remembering all of these funny muscles in the forearm, the flexor carpi, pollicis radialis, superficialis longus, which of course that isn't one muscle, that's just a meshing of all of the funny terms that are used. The best way to learn this stuff is to draw it in sequential order, just like I taught you. Pronator teres, flexor carpi radialis, palmaris longus, flexor digitorum superficialis, flexor carpi ulnaris. Okay, that's the superficial, and then you go to the deep. Flexor pollicis longus, flexor digitorum profundus, pronator quadratus. Yeah? And if you can do it and draw it sequentially, and you do that over and over again, it makes it a lot easier. Now, in the reading material, I actually have provided, or the reading texts have provided, these clear bone images for you to actually be able to draw muscles over the top. So, if you're having trouble remembering, then just listen to Leonardo da Vinci here, and he just says draw it, because that's what he did, and he was a pretty good anatomist. So, hopefully you've been able to retain some of this stuff, but we've got many hours in the labs to be able to practice this, and we're also going to functionally have a look at all this stuff in the pracs as well. So I'll see you somewhere in the future in the labs or the pracs. Thanks for listening.